Hi, everyone. Welcome to the podcast. I'm your host, Dr. Dean Mitchell. Grab a seat, get comfortable. You're about to enter the smartest doctor in the room. We are hearing a lot every day about artificial intelligence. We hear it's going to revolutionize the world. It's the biggest discovery since the Gutenberg printing press. We're also a little bit worried it may take away our future jobs. There are a lot of bold predictions out there and also a lot of uncertainty. However, medicine may be one of the areas where I can see AI being very advantageous. Personally, if I was asked many years ago, I would have changed the initials AI to stand for assisted intelligence, not artificial intelligence, because that's the way I see it. I think it shouldn't necessarily take the place of us, but hopefully it could be a very valued assistant in helping us do our daily tasks with the storage capacity of a computer. My guest today is a returning guest, is Dr. Michael Siegel. He's a top-trained pediatric neurologist who I've had on the podcast, as I mentioned before. And Dr. Siegel has another passion for computers, and he actually founded a company called SimulConsult. It's an AI company that's assisting doctors who are using their software to make more timely and accurate diagnoses. I thought it would be interesting to speak to Dr. Siegel today and really get a feel for how this works. So it's really my pleasure to have Dr. Michael Siegel back on the podcast.
Thank you.
Okay, so the internet already has a plethora of information, through Google and now ChatGPT. How are you going about organizing this software that differentiates SimulConsult from these search engines? And even, I guess, ChatGPT is considered a learned language model. Because you actually say on your website that your product is superior to those two things. How do you make that claim?
Well, you introduced the important question of what AI stands for, and people at the FDA have used the term augmented intelligence, which I think fits with the model that you're enunciating, and the whole field of medical informatics has used the type of model you were hinting at, which is not how does this do compared to doctors, but rather how does a doctor do with this compared to a doctor without it. And so I think there's two themes that we do that are very different from what other people do. One is that we see what we're doing as empowering clinicians as opposed to replacing them, which is the feeling of medical informatics in general. And the second is that we don't use, we're not just using the technique of large language models, which is based on a core principle of what's the next word that would fit here. It's a fabulous method if you're trying to translate text. I've had some of my stuff translated to other languages, and it's really, really good. And so there's definite fabulous advances going on. But when it comes to problems with the right answer, it's a very different question. And there was a great quote in an article recently from the chief clinical officer at Google saying that for certain things, artificial intelligence programs are going to go to tools that actually know how to do that type of computation well. It was an article about Diagnoses, but he also mentioned calculators and so forth. And I think we've tended to have a talking heads dialogue about artificial intelligence where somebody thinks it's all bad versus somebody who thinks it's all good, and it's ridiculous. There's going to be a whole bunch of things that these large language models do fabulously, and related techniques for radiology, pathology, and so forth do fabulously.
Yeah,
There's
looking
going to be things
again.
that just doesn't do a good job. And this was the theme of a chapter we wrote for the new version of the Swayman's pediatric neurology textbook, was really saying, look, it's everything is going to use some combination of various techniques, and everybody's going to be using some techniques to help them in their work, because there's just like so much more information than one could have imagined.
Right. It's like walking around with a computer like in your head, which none of us can do. What I've been disappointed about so far is that, I do sometimes Zoom consultations with patients, around the country, or even in New York. And the Zoom AI that does the transcription of the conversation, and there's another one now called Otter, I found them to be woefully inadequate. I end up finding myself correcting so much more than if I just, do my own notes myself. So while it would be ideal, I would love to have, or even of our Zoom, podcast, it would be beautiful to have a really nice transcript of everything that we've said. But I find that it makes a lot of mistakes. But I'm sure these things are going to get better and better. I want to ask you something too. Again, this is a whole new lingo. And, one of the things you keep hearing, because, everyone knows sort of how to do a Google search. You just kind of type in the box what you want and you get a whole slew of places where you could go for information, search essentially. Now they've been using this term called prompt engineering. They're making it like it's a whole new skill. And I was just curious, what would you say would be the equivalent for SimulConsult? Because that could be obviously a very important thing that for the future doctors and everyone to know how to use. Like, how do you get the most of this? And I know we're going to get into some examples because I want the listeners and people who view this on YouTube to be able to see how this is used. But is there any kind of training that goes into how to make yourself better at this?
Well, years ago, when I first expressed interest in doing something like this, I told the clinical geneticist with whom I was doing a fourth year medical school rotation that I was interested in doing something like this. And he had me spend a day with a program that the March of Dimes had spent $6 million on. And he said, tell me what you think. So I went back to him the next day and I thought this was not very good, not very helpful. And he said, well, that's what I told you. And I said, well, but you do it. Tell me how you do it. And it was one of the more illuminating experiences I had in medical school, because you think that you'd get told how to do diagnosis before the fourth year in medical school. And he said, well, look, I take the initial information and then I come up with a differential diagnosis. And then based on the differential diagnosis, I think, well, what's useful information that could distinguish among those possibilities? And we all sort of know that we do it, but we like haven't really been taught it as a method in that
Right.
sense.
Yeah.
And that's basically how the software was designed. And I went back to him years later and I showed him the software and he said, this really gets it. And I said, of course it does. It's doing what you told me to do.
Mm.
And so one of the things years ago, we talked to the people at Google and said, well, medicine is iterative. You come up with a differential, you ask more questions, you use pertinent negatives, you do all this kind of stuff. And they said, no, that's old school thinking. You put stuff into a search box and you press calculate, and that's it. You shouldn't need anything else. Now, one of the brilliant things about the recent AI revolution is it's completely blown up that view. It is iterative.
What do you mean by iterative? I'm sorry. What do you mean
The
by iterative?
conversations go on. You will say,
Oh, okay. It can gives you the next like sort of
well,
logic in
or
the.
you spoke about prompt engineering. So one of the things that you can do in even with the early models is say, well, what could I do to distinguish among? You could say, well, what are the
Mm.
5 most likely diagnoses, and then you could say, what could I do to distinguish among those
Ah.
diagnoses? So
Mm-hmm.
that's prompt engineering, but there's
Yeah.
there's much more to, that's the prompt engineering that you do as a user.
Right.
There's a whole level of prompt engineering underneath that, that you don't write a screenplay by just filling in the next most likely word and go on for 50 pages like that. There's a whole structure to it. And
Right.
that's the sort of thing nobody talks about, because
Mm.
that's the part that doesn't seem as sexy because it's like um, old style programming, but that's what really gives things the structure. And there have been various times where people have somehow gotten some of the prompt engineering and publicized it, the internal stuff. And there's a huge amount of structure to it, and nobody talks about it because they feel it's not as cool as the uh, uh, most likely next word part. But but both are important, and I was supposed to give a talk in Dubai recently about artificial intelligence, and it was I couldn't get there because of the last series of uh, flight cancellations because of Middle East tensions. But it had this slide showing the brain, the cortical areas and the subcortical areas, and I'm a neurologist and also involved in this whole AI thing, and the uh, the uh, large language models are very much like the cortex, terrifically capable, very much can be shifted from one area to another. Like if you're blind, your auditory cortex expands
Takes
into
over,
the
right?
visual
Yeah.
cortex.
Mm-hmm.
Um, and uh, and but there's a huge amount of important stuff in the subcortical areas. Like one of the areas we understand best is the hippocampus, which is great at locations of things, maps, where did I file this and stuff like this.
Mm.
And
It's
there's
memory, basically, right?
well, it's not so much the memory itself, it's the sort of uh, listing of where the memories are.
Okay.
And um, and so there's been these amazing neurological sort of accidents of surgery type of uh, uh, things about people whose if they lose the hippocampus on both sides, what kind of like they can uh, remember things from before the deficit, but every day you have to go in and introduce yourself again, and
Mm.
you'll be remembered during that session, but then you're starting from new the next day.
Mm.
And so there's amazing parts of the subcortical brain which are really, really important for how we function as people, even though we think of these as like the lower parts of the brain.
Right.
And we talk about the cortex as our sort of
The
great,
higher, yeah.
but it's the same thing with these artificial intelligence. There's the hidden prompt engineering, and then there's the large language models, and neither can do well without the other.
That's interesting. Let me ask you this too. When you were like putting together the, I guess the backbone, the structure, the content of this, did you have to, let's say, for example, go to top specialists, immunologists, hematologists, whatever, to get that information or to overlook it? You know what I'm saying? Like if you're putting in all of these diagnoses of leukemias or I just taught at the medical school immunodeficiencies, to come up with, again, and we're going to get into some examples because they're really interesting. These very obviously sometimes complex or rare conditions that your protocol helps assist physicians find. Did you have to go to these kind of specialists to get help in each category, or did you just feed in whatever was in, I don't know, the top immunology or Harrison textbooks? I mean, how did you
Um,
supply the content? I'm just curious.
we've done all of these. We've done textbooks. We've done various fabulous resources like the Gene Reviews. That's a NIH sponsored effort, and And we've done, and we originally we're in the early stages, we had a lot of information put in by generalists, but they quickly run out of steam and they sort of create a structure, and then the specialists really flesh it out. So we've used a whole variety of these things, and we have lots of original articles, and people use whatever they think is the most efficient way to get the right information.
Hmm. Because one of the things too, and this really goes back to, again, assisted intelligence, again, looking through some of your examples, which again, our listeners and viewers will get a little more of a taste of. I was again also struck by really the dependence of this on the physician, providing important details of either medical history or physical exam findings. I mean, a computer can't find an enlarged liver or spleen. That's a doctor has to put that in. Again, a really, sometimes very important medical history, maybe where they traveled or et cetera. Again, a computer can't get that. A doctor or a provider has to get that history. So in essence, I guess I believe that the software still really needs a good physician, that it can't just do this, blindly.
Yeah, of course. But one of the things that the software can do is highlight what information would be most useful.
Of what you should ask for. I mean, let's say
Yeah.
if a patient is, we'll just throw this out. If a patient has been complaining of some low-grade fevers and generalized joint pain, I mean, that obviously could be a lot of things. It could be a virus. It could be a lot of things. But I guess would the software prompt them, has your patient traveled anywhere, to a specific country or something like that? Does it do that?
So those are the types of things that come up in usefulness, but you'd also get, have you had fever? What's your ESR? And whatever seems most cost effective to do, and gives you
It will ask the doctor, did you order that? Or it'll prompt the doctor,
right.
Okay. What about also, I'm just curious too, because I assume that's going to be the case, that can doctors actually even upload, let's say, a photograph of a rash that they see in the office, or can they upload the actual diagnostic radiology picture, like a CT scan, that, again, those that could be extremely powerful, of course, with some labs that will start to really generate, an important differential diagnosis.
So people are starting to do that. There's a company called Face to Gene, which
Mm-hmm.
uses what I consider to be a lesser database about diagnosis, but they also analyze photos. And people have sometimes found this to be helpful, but it's an approach that in the long run should be very helpful. We're talking with another company about integrating in their input from that type of thing. But it goes farther than that. It could be pathology slides.
Right,
It
right. I
could
mean, anything visual. I know, like, as you know too, we've all taken our board exams, and they love throwing out these pictures of a slide or a photo, and they're great because they're usually very classical. But sometimes in life, again, we're all in private, we're in private practice or academic practice, and a lot of things. There's a lot of moving parts, and it would be like ultra cool to like be able to, okay, well, this patient has a, let's say the medical student comes to you or whatever, this patient has a rash. Dr. Siegel, Dr. Mitchell, and we say, okay, let's take a little picture of that. Oh, we have these blood studies. All right, let's upload it and see, again, what the SimulConsult or other, um, you know, AI model comes up with that we should really be considering, and because I also, just so you know too, I gave a lecture last week to the medical students on the immunology section, and I told them primary immunodeficiencies, which I teach, which just for the listeners is like the classic bubble boy, who if you got an infection, he would die. I said, we teach you that, close your eyes, and when you hear hoofbeats, now medical students always think of zebras. Us as, everyday clinicians think of horses, but somewhere in between, you have to, catch one or the other. So again, using this, how do you see, to catch, the horses from the zebras?
Well, I can actually show you a setting that we use for that. But
Okay,
to,
we'll get into it.
to,
Okay.
to get to your wider question, I think incorporating AI for those types of information is absolutely going to happen. It's very important. AI will do that very well. I can think of 3 models how that will happen. It's unclear how. Will it be like specialized programs like Face2Gene that will do pictures of a kid's face and hook into whatever database they've connected to? Will it be programs like ours that approach diagnosis in general, that bring in feeds from different capabilities like face or slide or radiology images? Or will it be these higher level programs like these large language models, which will query us? They will query that they will be the conveners. So it's going to be one of those 3 models. I don't know which. We've really had contact with people thinking of all of those 3, and we're pursuing all of those 3, and how it's all going to roll up into what you use in practice, we don't really know yet. At the moment, into our software, you would feed something like there's a short filter on your face, something like that. But eventually, images will do that better.
It's interesting. What I always also wished for, and I realize now why it would probably be a whole medical malpractice kind of issue, but what I would love to have for my practice is what I would call, an AI lab alert. Meaning, it's kind of ridiculous these days, but you know this too, we get the labs, they're highlighted in green if they're normal, red if they're abnormal, and sometimes again the value levels can vary. But what would be tremendous for a clinician is if the software in the labs, at least when whatever test you ordered, whether there's an extensive, chemistries or, immunology tests or infectious disease tests, if it generated a differential diagnosis for you. So for example, if some calcium was off and your potassium was off and this and that, and instead of just seeing high or low and then the doctor's thinking, oh, what is this, I don't know even what to do with this, it's like almost if it gave you that information saying, well, look, these are the 4 diagnoses you should be thinking about, just based on the labs, let alone whatever the clinical findings are. Does that exist yet?
Well, we do that already.
Oh,
So
really? Just off the labs, just straight off. If I let's say again, somebody I guess has a subscription with you guys. If I got the labs and several things were off that I was really confused about, I'm like thinking, I don't know, is this endocrine? Is this, rheumatological or something? I could send the labs or feed it into your consult, SimulConsult, and I would get a differential, a sort of a tiered differential diagnosis. Wow.
now typically people would use it to put in some physical findings plus some labs.
Yeah, well, that would be great too, of
But you
course.
could
Yeah.
put in, like if you're doing something like that and the person's having like persistent diarrhea, that's like relevant to
Yeah,
interpreting
of course. Yeah.
all these things. So, ideally you'd want to combine them all. And we actually have an interface where if you send a patient to a radiologist, for instance, the radiologist can filter the useful tests by radiology, and then comment not only on the pertinent positives relevant to the patient's clinical situation, but also comment on the pertinent negatives. Now, the radiologists are pretty good at commenting on the pertinent positives, but the pertinent negatives are also very important. When I was doing my pediatric neurology training at Columbia, we had once or twice a week, we had these neuroradiology rounds where we would go through an exercise like that, and we would explain what we were thinking, and then they would say, oh, but this, the corpus callosum is normal, etc.
Mm-hmm.
They would go through all sorts of pertinent negatives that they wouldn't
Mm.
normally mention. And the radiologists were good enough that they were going to tell us everything that was abnormal, but they wouldn't be as clinically attuned as to be able to tell us what was normal to rule out some of the things we were considering. And so the interplay of all of these elements, the labs, the clinical, the suggesting to everybody what's important to comment on, is the essence of great clinical interaction as we learned it, as we practice it. And what should be happening in software and what we do is to recreate that in a way that that allows decision support to help in that process, to encourage that process. And
Yeah,
that's why
absolutely. I've talked about this in other podcasts. I mean, one of the things that unfortunately has happened with medicine being so, it's become so automatic, mechanical, whatever you want to call it, and and again with all of the time required to put in data, doctors aren't talking to doctors as much as anymore. The hallway consults, the official consults, where doctors would literally talk to each other, talking about a case, bringing up really important ideas. Again, AI in a sense is your other eyes and ears to say, did you think about that? Did you do this? I mean, obviously it's more fun with a person, but this could be extremely valuable in a busy practice where they're seeing 20, 30 people a day. They can't get on the phone, with Dr. Siegel and say, Dr. Siegel, I've had this patient with seizures and da 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 da. Have you seen a case like this? Whereas they could feed this in quickly, to the AI and get hopefully important stuff. My other question to you though is, again, in using your company, SimulConsult, do they have to, it can't be interfaced into their computer or into their electronic system already? Do they have to, let's say, sort of take whatever that data is and then enter it into your program, or is there a way that it's interfaced almost automatically once?
Well, that's how it started out, was completely separate. What we've added recently uh, is natural language processing, where you can paste in and it'll recognize what you're talking about.
Hmm.
Uh, and the we're also working with integration into electronic health records, and uh, and that would feed in the information. And there's and you'd start out knowing how old the patient is and all that kind of
Hmm.
stuff. And a lot of the stuff that you'd have to do if it's independent would already be done because you already have that information.
It's so fascinating too. It's kind of the fun of what I do in my podcast here. I had on a couple of weeks ago, Tony Dehar, who's an ER attending. I think he's with Weill Cornell, but he was downtown. He just recently retired. But one of the other things that he did besides working in the ER and teaching medical students, he was involved with what's the right word again? And essentially, he was auditing the charts. I forgot the name of it's like a committee or something.
Uh,
And what was interesting was, so what they would do, being on this committee, get whatever how many times a year they met, they used to look over case records of everybody who'd gone through the ER, and look at certain diagnoses. And one of the things that they found, he wrote about this in an article in Discover magazine, and we talked about it a little bit more, was that what we found in this, like in these malpractice suits, whatever, too, that in neurological conditions, the biggest miss for the herniation of the lower spine, I'm blanking on the name right now, was that it was bilateral symptoms. A lot of people can get like unilateral symptoms, but it's the bilateral symptoms that are, about cord compression. Those are the most serious. And when they, again, looked at the data of the lawsuits, they saw that that was the thing that was missed the most. Even they recorded in the record, the person had bilateral, numbness, but they sent them out to go follow up with the doctor, not realizing it was a medical emergency. So again, I could see this kind of thing too being tremendous in analyzing even prior data to pull out key things, right? Do you do any kind of work with that at all? I was just curious.
so I just start out by mentioning that one of the findings we have is unilateral localization, uh, and you can get into situations where it'll ask, is it unilateral?
Hmm.
If it's weighing between two
Hmm.
diagnoses.
Yeah.
Uh, Another thing that we do is we call case-based quality improvement. So a certain fraction, a small fraction of our users are empowered as curators. And instead of having the general database, they have their own database. Um, and they can then look at a case and say, oh, well, this should have been higher. Let me look. And oh, we didn't say that it was unilateral. Then put that in. And then that gets automatically submitted to be part of the general version and part of the base of their version. And so you can easily see how a process like that, if you have great clinicians in a bunch of fields, all feeding in a lot of stuff about their cases,
Yeah.
you're going to know the information, like your previous guest was mentioning, won't need to go through a 19-year process of getting into the literature and being proven in NIH study.
Right.
As
Right.
long as it's known to be true, you can just put it in and it will uh, minutes later come up in when people are trying to make diagnoses, and they'll get asked about it, and it'll influence a differential diagnosis.
Yeah, that's really valuable. Let me ask you something too, because I don't really understand a lot of it yet, but you have like some kind of program called the Genome Phenom. Sounds like a sports analogy. Genome Phenom Analyzer. So I'm going to ask you what that is, and I want you, if you wouldn't mind too, comparing it to something like 23andMe. Now, I have patients that do this 23andMe thing, which I'm not so in favor of. I just feel like genetic medicine is still a little bit early. And I think sometimes people are going to find out things about themselves that can't be treated. Again, I don't know how accurate they are. I mean, I know I understand a little bit about epigenetics, meaning you can have obviously certain genes, but do they get turned on? So what is your genome phenome analyzer? What does it do?
So, in some ways, the mother of all lab tests is a genomic analysis, whether it's an exome or a genome technique. And
Mhm.
they have a huge amount of information, and you'll typically get back a few thousand variants that are sort of different from the reference genome. And and then it becomes a matter of which ones are clinically relevant. And so we do the clinical correlation. And so we have a metric whose name you'll recognize as pertinence, that you always ask about pertinent positives and pertinent negatives. So we've given that a mathematical meaning, and we can calculate which genes are most pertinent according to how much they change your differential diagnosis. And so it turns out that the gene variants that are most pertinent are uh, are typically the diagnosis and what's wrong. So we can do that analysis, and we can do it in like a minute or so. I mean, the whole calculation takes a few seconds, but it takes you a few minutes to look through it. And so it takes that technology and can bring it to certain clinical situations. Now, in immunology, you're not going to often be using that, although uh, in recent years there's been a huge amount of knowledge about genetic uh, variants that result in immunological conditions. So
Right.
it's the wave is moving over there. Uh, but in certain areas, and particularly where we started in pediatric neurology, there's a huge amount of genetics, and very often you'll be ordering these tests, and often what people do is they construct a panel and they put on blinders and only look at that panel. And so that's a lot of the use of the genomic techniques are used for that. And the reason is people don't want to be fussing about all the other stuff. But in our analysis, it just happens automatically. And if you do a good genomic analysis, there, maybe will be 10 variants you have to consider, of which like 9 of them are going to be pretty much irrelevant. And so this is part of bringing down the costs of using all this information. Now, you're not going to do it for everybody, although 30 years from now, it may be that we're just going to get a genomic sequence for every kid.
But do you
And
think it's dangerous in a way too? Like I always like, I'll give you a good example. I was just listening today to someone who's, as a doctor, you hear everybody's stories, whether they're your patient or not. Like there was somebody who was telling me about in their family, the older sister had Parkinson's, the grandmother or somebody had Parkinson's, and and now her husband has like a little bit of a tremor, although it's like a benign tremor, and I don't know, is it valuable really if somebody even in their 30s or their 40s does a genetic test that finds that they have a high likelihood of Parkinson's, if that even exists, I'm not even sure. I mean, because to me, again, in some of these cases, especially in neurology, in your field, there still aren't a lot of treatments. And I don't know, is not knowing sometimes better than knowing?
Uh, well, for Parkinson's disease in particular, there's a whole bunch of genetic forms.
Mm-hmm.
They still account for just a small fraction of
Mm.
the total incidence of Parkinson's disease. Um, and other factors like head trauma and who knows what else are very
Right,
important.
sure, like, I'm sure environmental things, if you drink heavily or, whatever, yeah, or you're a polluted area or something. I mean, there's other things, a lot of things we don't know. And the microbiome now is getting a lot of attention in Parkinson's disease.
So for diseases where, like, if you've had a kid with a inherited neurological disease, it would make a lot of sense to check if your next pregnancy has that.
Okay.
Uh, if there's been a lot of agonizing over Huntington's disease.
Very scary, right?
If you're a 30-year-old, do you want to know? Do you not want to know? I mean, both of them are very defensible positions. Uh, and it's particularly tough because the onset is so late that if you check whether let's say a woman is pregnant and her mother uh, has Huntington disease, one could argue that it's worth checking for a pregnancy to not pass it along to a third
Right.
generation. But that, since it's a dominant condition, if the kid has it, the mother has it too. So she'd be finding out about herself. So these are like
Yeah,
enormous.
right. These are heavy duty. I have somebody coming up in a couple of weeks, a bioethics guy from Columbia. I don't know if you know Dr. What's his name? You probably do know him. Dr. Kitzman. I don't know if you know him. He's like a big bioethics guy at Columbia. But
Uh, when
I
I
might
was
want to
a
ask, I might
medical
want to ask him about this one. This is
when I was a medical student, one of the sort of very early bioethicists uh, was trailing along with us on internal medicine rotation. So Columbia has a real reputation for taking that seriously.
yeah, yeah. What about treatment? Okay, one of the thing too, again, I think the only way I've heard it's been used, like IBM, I can't remember, was it Einstein or Watson, one of the geniuses, whatever they called it, was supposed to be this incredible machine, for medicine. I don't think it really ever panned out. But the one thing I saw, I think it was on 60 Minutes several years ago, was that it was supposed to help doctors in clinical management, meaning, it would spew to them the latest articles, so supposedly help, you know, um, make sure people across the board were getting the best treatment. Did that ever really pan out? And does your software do anything like that either? I mean, once people know what their diagnosis is, do you lay out for them, okay, this would be the best treatment in most cases, or no?
Well, Watson wasn't designed by clinicians, and we
Mm.
actually showed our software to people from the Watson team, and they were just like their jaws dropped in terms of
Ah,
all the
okay.
complexity that they weren't dealing with.
Uh-huh.
And one of the other issues with Watson is that it didn't come with data. It would
Mm.
crunch your data.
Hmm.
And so there's a question of that, did it really crunch the data of Sloan Kettering better than Sloan Kettering knew about its history and so forth?
Hmm.
And so it never really caught on that well because it really wasn't offering that much.
Hmm.
Um, and the crunching the data was important because it helps you with what's a good treatment and so forth. So we don't do treatment explicitly, although we divide diagnoses pretty finely. So we don't just say you have epilepsy, you have one of these 1,500 genetic conditions with epilepsy, some of which are treatable, et cetera, et cetera. So we do approach treatment in that way. And then we link to resources that talk about treatment, but we haven't seen treatment as being the core of what we do, and other people are doing good stuff about treatment. So there's always a certain modesty in saying, this is what we do, and we're not going to just try to do everything. We're going to do what we do well and connect it up to other things.
Makes sense. All right, we're going to get to as we're getting toward the end of the podcast. I want to do what the sportscaster, I forgot his name, something with a W, used to say, let's go to the videotape. So let's go to, I'm going to let you share the screen because I want to, for our people who are fortunate to end up seeing this on YouTube, go to what this looks like. And I'll let you take over, Dr. Siegel, and
okay,
narrate
so I
us
can
through
illustrate
this.
a few of the points that we discussed. So if this were connected to an electronic health record, I wouldn't have to put in the age and the sex, but I'll do it because we're using a standalone version.
Okay.
Now, we talked about zebras versus horses. Primary care is horses, tertiary is zebras.
Right.
This was, I'll show you a patient from the New York Times Diagnosis column, and I'll call that somewhere in the middle, presenting.
Okay. Yeah, Lisa Sanders has very, one of the quick things I was just going to interject. What I love about what you're doing, and I talked to Dr. Sanders about this on my podcast years ago. I said to her, one of the things, the overriding themes that struck me about her articles, which are always well written and very interesting, is the time sequence that passes till the diagnosis is made. I mean, typically in her cases, you hear about her patients bouncing around from one to the other. And I also, unfortunately, did a video on myself. I called myself the 10th doctor because so many patients have been at least to 9 other doctors before they came to me about their immunological functional medicine issues. So yeah, I think I'm anxiously awaiting to see how you dissected her case. I'm sorry, go ahead.
Yeah, and they often involve going to some expert in the corner of a library somewhere who figures it out, who
Right, yeah,
remembers the important thing. And it's anyway, what we do has less drama, but it has less delays.
Okay.
And that's what people are ultimately after. So I extracted some of the text from one of these cases. I'll paste it into our natural language processing. And then I'll load that, and this shows another way in which the doctor is kept in the loop. That here are the findings we recognize, and you could, if this were a longer text, you could click and find out which sentence we found it in, and so forth.
The green flag means that this was present.
Or that we detected this.
Yes. Okay.
We detected a mention of this, but here we'll call this absent.
Okay.
There's no fever.
Okay.
And now I'll start commenting on some of the findings. There was myalgia, and that was of relatively recent onset. We take onset and absence into account, which is really important. And one of the things that we have curated information, so we know the frequency of findings in the disease. And that allows you to use pertinent negatives, which is a hugely important part of medicine, which the large language models really can't do well because they don't know how frequent something is and whether it's meaningful if something is absent. So anyway, so put in the myalgia, and we're starting to come up. We're starting to display a differential diagnosis, and you can't see much of. There's some blue shading for the differential diagnosis probability, but there isn't much of anything yet because we don't really know.
Why did they start a couple of things like statin associated myopathy? Because they're more common. Like, why those start?
No, so I'll click that. That these may increase the certain drugs may increase the risk of muscle damage from statin.
Right, but it's starred on but why is it starred in the,
It started to tell you there's something non-obvious about the disease.
okay,
If you know this, don't give them these drugs.
right, okay, that makes sense. Yeah, that's great.
Uh,
Okay.
and so I sometimes have shown the Libby Zion case that triggered in New York, that triggered the restrictions on doctors' work hours. And with serotonin syndrome, we have a star to tell you don't give them
Right,
drugs like Demerol.
right, right. That should be in the pharmacies, but yes, yeah. In
Yeah,
the
but they often,
hospital.
they won't have all the information.
Yeah, okay.
So there was this case described, this strange and persistent nasal discharge that went on for months.
Mm-hmm.
Uh, and exercise intolerance, and steroid treatment was used, and it really improved the situation. So now this is shifting to a general display of all findings instead of just the flagged findings. And so there's a bunch of things here, a bunch of diagnoses. A few of the ones with most blue are rheumatologic, one that isn't. But as an empowered clinician, I would quickly say, have you been taking aspirin? And the answer is no. So that knocks the aspirin
Mm-hmm.
related disease down, and sort of we're basically have a horse race among 3 rheumatologic conditions.
Mm.
So our view of how they
Because this is tiered as to the most likely, is that correct?
correct. So the blue shading is probability. So it's a 40% chance of eosinophilic granulomatosis with polyangiitis and so forth. But any of these other conditions has a realistic probability. And so it's asking about various things. Are there recurrent episodes?
Mm-hmm.
Is there chondritis of the external ear?
Mm-hmm.
I could put that in. In this case, actually, the guy was noted to have like really bright red ears, which was probably chondritis. And you could use various, if you highlighted that, you could see which diseases it's present in, and it's in this differential, it would make a big difference. And you could store this information at this point. So let's say that you're the resident, you're writing your note. We're going to order some labs. You can get some advice on the labs, and but then you want to store what you have. You could put that in a way that I'll simulate with a chart note of findings only, where it takes the findings and uses human phenotype ontology codes to just create a sort of a finding list, the pertinent positives, pertinent negatives, and then a URL that allows you to jump back into it. So you can imagine if you're the radiologist, you're yourself after an hour when all the labs came back, you would just click in the note and you'd be back where you started with these findings. And let's say you ordered some tests. So we separate the general findings from tests because that's what we do clinically, because things on exam you get for free and you get instantly, while here the top things that are coming up are a CBC and a urinalysis, which are very often ordered in rheumatology for good reasons.
Yeah.
And so here, the top thing in the CBC is checking eosinophils, but the article didn't mention that because it wasn't about the differential diagnosis. It was about the actual diagnosis. And, that's clinical medicine. You're looking ahead, you don't know what the answer is yet. And, in people outside of medicine say, oh, the real sign of great intelligence is to be able to have 2 conflicting possibilities in your mind at the same time. Well, we do that every day. We call it a differential diagnosis.
Right.
But anyway, it doesn't make for good journalism because you'd have to discuss the differential diagnosis. But in the urinalysis, the top thing is hematuria. And hematuria is present in this third diagnosis, granulomatosis with polyangiitis, and
Is that the same as Wegener's? Is that you calling it the same as Wegener's or no? Just out of
yes,
curiosity.
it is, but a lot of diseases, particularly in rheumatology, are being
Changed from
named according to the phenomenology, and
right. Okay, I just noticed because I think I know what this case is, and I'm gonna tell a nice little story after if it turns out what it is. But anyway, okay.
and I mean, and some of the people after which these diseases were named had unsavory backgrounds. So
Right, right. Some of them were like the Nazis or something.
right.
Okay, Nazi doctors. Okay.
So anyway, so you could argue, would you say hematuria is recent because had a, let's say yes, because had 6 months ago had a checkup with no hematuria. And so that pushes granulomatosis with polyangiitis up to the top of your list. And so you should take it really seriously as a diagnosis. And that turned out to be the diagnosis in this case, although they did other things. So let's imagine they went next to they actually brought in the radiologist. So let's filter by radiology. And the top is chest imaging, which has many things you would notice on chest.
Mm,
And they noticed pulmonary nodules.
mm,
And the onset was unknown because you don't look in every year at your annual checkup for pulmonary.
mm-hmm.
So it made a decent case for granulomatosis with polyangiitis, and you can uh, you can do what AI doesn't do. Is uh, uh, there? It's said that there is no explainable AI, but our augmented intelligence is explainable because we can show you all the findings, uh, the pertinent positives and the pertinent negatives, and we can color in black the fraction who would have it during the period we said of recent or just present by any point. And in orange is the fraction who would have had it before, purple later. So a lot of black up here is a good match. A lot of black, a very little black down here is a good match. So it goes against the diagnosis a bit that the patient doesn't have fever, but who knows? They may have had fever 6 months ago or whatever.
So how long does it take a doctor if they're fairly well trained? And I want to ask you how long it takes to get training. Let's say a doctor that's very well trained in this, how long will it, I mean, because this is taking time now, how long would it take them to go through this, would you
Uh,
say?
it should take just a few minutes for them.
Really? I mean, like 5 minutes, or it would take like 25 minutes
No, no,
to,
no. The geneticists analyzing genome or exome say it takes them 25 minutes.
no, but this particular case, I mean, we're going through it carefully and slowly. How long, if a doctor had gotten this stuff and he's looking at the chart and filling in stuff, let's say he got this case, how long would it normally take him to do what you're doing now? Obviously,
I would say about 3 minutes.
really? Hmm.
I've been taking the time to show you various
No, I
features.
know. I appreciate that. No, I was just wondering though, because it does still seem like a lot, but it's incredibly worthwhile for sure.
Now,
Um,
it'll take you an hour or two to get up to speed and all the features and
Makes
so forth.
sense.
But, we train in medicine, for like 8 years or so, if you count medical school. And it would seem worthwhile to add another hour or two to your training to really buff
Oh,
up.
absolutely. Absolutely. I'm going to interrupt you here for a second if it's okay, because I have to tell this story, which relates exactly to this case, which maybe will bring a smile to your face. I'll never forget, this was gosh, 25, 30 years ago, where I was working in an office, and there was another staff member there. She didn't work for me, but she was a really nice medical assistant, and she came in, she was in tears. She was beside herself. Her dad, who was like in his mid 60s, at first she said he actually was hospitalized with kidney failure. And then on top of the kidney failure, they said, oh my gosh, looks like he's got lung cancer on top of his kidney failure. And she was beside herself. And it was really sad. I mean, she was very close to him. He was a very vital guy. And it turned out after, I guess, they stabilized his kidney failure with dialysis, and they eventually did a biopsy of his lungs to see about the cancer. It turned out it was what we call a granuloma, which you've been going through. It's just essentially a bunch of inflammatory cells forming, forming a nodule.
Right.
Now, so he ended up getting diagnosed with what we called Wegener's granulomatosis, which you're calling polyangiitis. And I found that fascinating because it kind of fell into my area of expertise in allergy and immunology. So I actually sat down with her and I was curious. I said, I was curious to hear her dad's history. Like, why did it take so long? And then she started telling me, and this is interesting where your stuff really comes in amazing. She goes, it's funny. She goes, Dr. Mitchell, I remember my dad always having really bad sinus problems. She goes, I remember his third, whatever, like, when I was a child, whatever, too, and he was 30s or 40s, he was always complaining of his sinuses. He lived on Afrin, and I think he had one or two sinus surgeries. She goes, then later on in his 50s, again, I guess not so unusual too, he ended up having bypass surgery, for his heart, and they did the bypass, they patched him up there. She goes, and then now he was, I guess, in his late 60s or whatever. Yeah, in this case, he had bypass surgery. So it seemed like everybody kept on like just patching him up. And then, several years later, I guess it wasn't followed, or it wasn't picked up, that he ended up presenting in kidney failure and he had fluid in his lungs, and he had the granulomas in his lungs. And remember kept thinking, and he was very sick. He was obviously on dialysis. I think he passed away. But I kept thinking to myself, gosh, in my field, I see so many people with sinusitis. How do I differentiate that one person that if I catch early enough, that it's not due to an allergy or polyps or something? And, again, something like your software, somebody who's taking a step back and thinking about, in this case, the zebra, it could be life-saving.
Yeah, absolutely. And that's the whole idea is that there's, you have a room of 100 good doctors and a few of
Yeah.
them are going to recognize this. And the point of doing software like this is to pool that expertise together. So everybody's benefiting from everybody else's expertise because, each of us knows certain things really well, but not as well as certain things we don't know as well as other people in the room.
Yeah, you just don't want to end up being like one of the case histories in the New England Medical Journal. It's usually somebody who's been through a lot, when you read those cases, in the most famous journal in the world. Dr.
Yeah, we're
Siegel,
starting
so
we're
yeah.
starting to do a cases blog of
Oh yeah,
taking some of those cases and running them through the software, and they would have been helped.
really. I'm sure they would have. So let me ask you, as we're concluding here, if a doctor, or I don't know, can a patient even sign up for your consultation program? How would that work?
Um, well, currently we have two chat versions of this interface, which are sort of addressing your question of how long does it take to learn this. So obviously, it would be impractical for a patient to learn this interface.
Right.
Uh, and but also some general practitioners just want something more similar. So we have something with the feel of ChatGPT, except it really thinks like a doctor. And but we also have something for patients where it doesn't disclose the differential diagnosis, but it does use this logic to, in this situation, it would like ask you, do you have hematuria or something like that? And although a patient can't test that themselves, they may say, hey, yeah, that came up on my checkup, but nobody, the doctor
Addressed it, yeah.
called me back about it and never put it together with the other stuff.
Does this also pose, I know I hate going in this direction, but does this pose a little bit of a malpractice risk for a doctor if they do use your services and it, you know, they don't correctly apply it?
Um, well, the doctor is still the one responsible for the decision, and
Right.
the malpractice question I think comes up more the other way. Like, what if the guy in the next office
Picks
has
up.
this and would have gotten it right?
That's true.
So the legal standard, as I understand it, is to be as good as the average doctor.
Right.
But what's it going to be like in 10 years?
No, you got to be better.
Is it going to be like the average doctor without software, or like the average
Right.
doctor with software?
Right. Great point. Great point. This was such an illuminating discussion. I am so glad I have you back on. I'm always on the lookout in the Wall Street Journal because you always write these great opinion articles on so many topics. You're a man of many talents. Any kind of handoff I can give for our listeners who want to follow any of your work or what you're doing?
Well, there's our website of simulconsult.com has various things like some of these cases, and uh, and has some videos and things like that. And basically, I think it's important that doctors start being as good as they can be.
I agree with you 100%. That's what this whole podcast is about. The smartest doctor in the room is just getting better every day. Because if you're not, you're getting worse. So again, Dr. Michael Siegel, thank you for taking the time to come on. I hope our listeners appreciate this. And again, if you want to see exactly how the SimulConsult works, I think it's very illuminating to go to a YouTube. We'll have that on. And until next time, everyone, take care of yourself.